Dear colleagues, congratulations to all of you because you have made your work through to the paces. And as you know, you might be surprised to hear that paces happens to be the easiest part of the entire MRCP membership curriculum. If you are amused to learn that, let me tell you that ever since I have appeared in the membership exams, I have participated as an examiner, as a trainer. I have found it's the easiest path to get through, to crack through, because if you just follow certain rules, if you just practice hard and practice repeatedly, paces is just a cakewalk. I have put up the MRCP carousel, paces carousel, which is just a representative of what a carousel might be. The carousel might come in surprising combinations. Click, please. The next one. Yes. So you can see it's almost the same, only a little bit of different in combination. So anything can be your station 1, anything can be your station 2, anything can be your station 5. So don't be under the impression that abdomen will always appear in your station 4. It might not be so. It might not be abdomen, it might be communication, it might be something else. So, abdomen is an important station, it's a 10 minutes session. But also do remember that when you are doing a brief clinical consultation, you might also be required to examine the abdomen as fast as possible. But that is not what we are discussing today. We are discussing abdomen as a station, how to go through, how to examine the abdominal system or the GI system, uh, particularly to fit into the shoes that they want you to wear for paces. Next one. So, what are the common encounters in the abdominal station? So, certainly this list is a representative, and these are the cases that commonly keep coming up for the abdominal station. But these are not all. You might find other combinations. You might find very bewildering combinations or a very rare disease that has been put up due to the paucity of actual cases. But let me tell you that every convener, every examiner, every center is very particular about bringing in the prototype cases, which they want the would be consultant, the would be medical consultant to be conversant with. So there is 90% or more chance that you will get the common encounters, but they may come in varied combinations. So in renal diseases, you get renal transplants, you get adult polycystic kidney disease. I mean the ADPKD, autosomal dominant polycystic kidney disease. You might get a now, here is the twist. You might get a patient who is neurologically compromised due to a stroke, and yet the patient is there in the abdominal station. So, these are the twists that you should expect. Now, you might have a patient with chronic kidney disease, you might have a patient with a nephrectomy scar. Next one. Next, probably is the hepatobiliary system. You might get a chronic liver disease with or without a liver transplant. You might get a cirrhotic patient, the commonest of the hepatobiliary as well as the abdominal cases. You might get a acute liver failure for varied reasons, the commonest being paracetamol overdosage, and you might, in a lesser proportion of probabilities, get a hepatocellular carcinoma. Next, please. You have a splenomegaly and splenectomy kind of coming up very commonly in our country. If you are appearing for a center which is there in India, there's higher chance that you might get a splenomegaly case, and this is one of the easiest encounters and the most difficult to pass as well. Next. Next are the miscellaneous conditions. Other relevant conditions like vague abdominal pain, ascites, abdominal aortic aneurysm, very rare. Abdominal muscles, quite common. Small bowel obstruction, very, very rare again. Inflammatory bowel disease in remission. You wouldn't get a very acute inflammatory bowel disease. Then you get a pancreatitis, usually a chronic one or an acute on chronic one. You might get a cholecystitis, usually with or without gallstones, but then again, it's a chronic calculus or acalculous cholecystitis. Gastroesophageal reflux disease, they'll give you GERD only if they don't have any good cases. And finally, gastritis or peptic ulcer disease. If you have got one of these last two, be very, very particular, be very, very meticulous, because your passing would be more dependent on how you examine the patient and how you tell your DDs. Next. So we are now approaching the patient. So, as you all know, introduction is very important. You have to introduce yourself. You should elicit the name of the patient, the age, and the occupation. One good way of doing it is telling the patient his name or her name, the age, and get it validated from him or her. Or you can have an open question like, I'm Dr. Swan, so a house officer looking after your case today or looking after you today. May I check your name and age? Never say what is your name, because you are supposed to know the name of the patient. So you are either checking or validate. Next is you have to explain the examination to the patient and seek consent. Tell him or her that I'm going to look after your tummy. I'm going to take a look at your tummy. I'm going to look at your the organs inside your tummy. I would look at it. I would have to touch it softly and then a little bit deeply. And I might also do a little one or two maneuvers or one or two procedures on you to find out the right findings. And you have to position the patient. We'll talk about that in a short while from now, but ensure that the patient is lying flat or a little head up and the patient has been exposed appropriately, but exactly the portion that you wish to examine has been exposed and nothing more than that. Offer chaperones for both female and male patients. This is something that you should remember by heart. Do not forget asking for a chaperone in case of a male patient as well. You should wash your hands, or better, you have to sanitize your hands. And if there's a oozing wound, say you have an abdominal scar which is oozing pus, if you examine that, you have to sanitize your hands and ask for a pair of gloves. Next. So you start off by a general inspection, usually by looking at the patient from a distance. There might be a very crooked examiner who would deliberately turn off a light inside the room, making it difficult to examine. So you have to ask for a, if you find it awkwardly dark, if you find it awkwardly underlighted, under illuminated, clearly ask the examiner if there's any second light in the room, or if you can arrange for a light, and they will definitely turn on one which they have deliberately turned off. You look for the scars, you look for a distension which is obvious, you look for masses, you look for a stoma, ileostomy, colostomy, or a gastrostomy, feeding gastrostomy with a peg tube. You should look for hernias, you should look for any discoloration, jaundice being one of the many, and indwelling catheters, if any. Look for any movements, including gastric peristalsis or pulsations. Describe the abdominal contour as flat, scaphoid, which essentially means sunken or protuberant. Next. So I guess these all of you know, these are the different type of scars. You should remember them by heart, because if you fumble, if you fail to identify a very typical scar and you would be given a very ideally looking scar, then you're certainly going to fail in that station. You're going to fail the entire examination. Scar is so very important. Or if you fail to identify between an ileostomy and a colostomy, or if you miss something like the icterus, the deep icterus in the lady at the bottom left, or you miss an obvious swelling like a hernia or a bulging aneurysm. Next,